to the School of Graduate Studies 3-minute thesis. To begin, I would like to acknowledge that Queen's is situated on traditional Anishinaabe and Haudenosaunee territory. By mentioning the history of this land, we hope to educate, to create an awareness of Indigenous histories for both domestic and international graduate students as part of this institution's desire to foster inclusivity on campus and to encourage reflection on what it means to occupy this space. We offer this acknowledgement and recognition, respect and gratitude for the Indigenous people who have lived on and continue to live on this land and with whom we share a community. Just before I introduce you to our Dean, I would just like to mention everyone after each presentation, if you wouldn't mind, you can ask questions in the Q&A tab. But with that, I'd like to introduce you to Vice Provost and Dean of the School of Graduate Studies, Fahim Kadir.
Good afternoon, everyone, and thank you, Colette. And I thank all of you for taking some time off from your Saturday afternoon to join us for this 3-minute thesis presentations. There will be 2 sessions. This is the first session for us to hold. For some, 3MT is a competition. I don't see the 3-minute thesis presentation as a competition. It is primarily about celebrating graduate students' research. Most of you know that graduate students are key drivers of innovation for our society and economy. They push the frontiers of research by being bold, by undertaking research projects that will be difficult for many of us to tackle. They deal with complex socioeconomic issues and look for opportunities to address them. Their novel ideas and groundbreaking discoveries not only enrich our intellectual world, the academic world. More important for me to mention that the research helps us find solutions to pressing challenges facing the world today. And 3MT is an event that allows our graduate students to showcase their cutting-edge research, the research they carry out on issues of local, national, and global importance. With this rather short welcome, I would like to introduce our first presenter, Samantha Twitner. Samantha is a doctoral candidate in the Department of Political Studies in the Faculty of Arts and Sciences, and she was the winner of this year's 3MT event. Samantha is being supervised by Dr. John McGarry. The title of her presentation is Scared of What Behind You, Negotiating the Double Minority Dilemma. Samantha, please welcome Samantha in making her presentation. Samantha.
Thank you. Let me begin with a scene from The Lion King, where Simba the lion cub comes face to face with 3 menacing hyenas. Outnumbered and overpowered, Simba is surprised to find the hyenas cowering in fear to his suddenly powerful roar. But of course, the hyenas are not afraid of Simba. They are afraid of Mufasa, who has intervened and is now standing behind the cub. In turn, the hyenas will enlist the support of Mufasa's brother Scar, and this will escalate tensions. But what does this have to do with negotiation? Well, to begin with, this is a security dilemma, where one party's efforts to increase their security position will inevitably decrease the security of their opponent. My research looks specifically at a type of security dilemma that I call the double minority dilemma, where both parties to the conflict see themselves as the minority under threat, and therefore deserving of concessions in negotiations. This is because when they look across the table, rather than looking directly at their opponent, they are looking at power and authority they perceive to be standing behind them. So in Northern Ireland, for example, the Protestants are the majority and they control the government. But they see themselves as a minority on the island of Ireland and therefore under threat. Of course, the Catholics of Ireland look at the United Kingdom and say that they remain the minority still. In Cyprus, we have a similar dynamic where the Greek Cypriots are the majority on the island and they control the recognized government, but the Turkish Cypriots enjoy the political, military, and economic support of Turkey, which makes the Greek Cypriots a minority in the region. When we intervene and add more parties to these conflicts, we increase this dilemma. So in Northern Ireland for many years, the US was seen to support the Catholics, and the European Union is seen to support the Greek Cypriots in Cyprus. My research found how the parties to the conflict in Northern Ireland were able to perceive the United Kingdom, Northern Ireland, Ireland, EU, and the United States were able to balance their relationships such that this minority was reduced and a settlement was possible. This is actually important for understanding the new conflicts emerging as a result of the border protocol and the post-Brexit tensions. In Cyprus, however, the parties to the conflict continue to see interveners like the EU and the UN as one-sided in their support, and this prevents them from successful settlement. When we look at other cases like Syria or Israel-Palestine, we want to make sure that we are not Mufasa, where we are increasing tensions through our intervention. My thesis frames and informs an approach to understanding what we might be bringing behind us, such that we can ensure our interventions are peace-producing rather than conflict escalating. Thank you.
Hi, Samantha. Thank you so much for that. That's a great start to this 3MT. And said Samantha was our winner this year of the 3-minute thesis and has had opportunities to present in similar formats at other times. So Samantha, what did you think about this 3-minute version of summing up your thesis, which we know is can be an awfully long book?
Thanks. Yeah, it was really a challenge for sure, and one that I was welcome to take on, because one of the struggles I was having with my thesis was focusing on what really was the heart of what I wanted to say. And having to crunch down all of my research into 3 minutes really, really gave me that insight. It really made me focus in on what was most important that I needed to say in my thesis. So in that way, I think it's also made me a more effective presenter in other ways, because now when I do other conferences, I also go, what is the most important thing I need to say? And could I do it in 3 minutes?
Well, it's interesting too, within your thesis, even with this, you brought 2 scenarios to the platform, but then you mentioned another couple, like, with what's going on in Syria and what's happening in Palestine, Israel. So how did you find focusing in on 1 or 2 only? Because really there are all sorts of different chapters there that you could go into.
Yeah, so these 2 cases have a lot in common. So when it comes to methodology, I'm following a most similar case design. But more importantly, the shared district around the European Union is important to my thesis. I actually do look very specifically at how the European Union provided for an atmosphere in which these types of relationships could be built, and in fact, how it interrupts those relationships in Cyprus. So that made these cases in particular unique and better for that argument. But in choosing them out of the gate, I will admit to sort of basics. I did my MA in Northern Ireland. I was confident in the conflict. I understood it. I'm working with John McGarry, who is an expert on both Northern Ireland and Cyprus. And so I came to understand Cyprus in a lot of detail early on in my PhD as well. So there was a little bit of making life easy for myself in selecting these cases as well.
That's always interesting. The thing is about doing a PhD, along the way, things can change for you. And of course, if we're looking at Northern Ireland, the effect of Brexit, right in the middle of you doing your PhD and your research. So have you had to change a lot of those chapters, or are you just going as is?
No, absolutely. My research was interrupted a lot, actually. I started with a project that was on Iraq. And then I was not allowed to do that because of international conflict and turmoil. So when I settled on Northern Ireland and Brexit happened about a year later, while I was doing my fieldwork, it was rough. No one wanted to talk to me. So my methodology of doing interviews was completely disrupted by politicians not wanting to speak to anyone. As well, I kept having to decide whether my project looks at 1998. I look at the Belfast Agreement and how they got to that point. And it's really difficult because everyone I did talk to wanted to talk about current events. And so trying to make sure that my thesis didn't spill over into talking about Brexit, but more informed it, right? Where the research focuses more on 1998. And then at the end, final chapter, by the way, has been a little tricky, but I've tried to not let it alter my research too much.
Well, we take your hat off to you, and you clearly got plenty to talk about. So thank you very much, Samantha, for getting us started on this first session of ours. And don't forget, everyone, you can, if you've got questions yourself for our students, please put them in the Q&A tab, because I'd love to be able to pass on your questions. So thank you for that. So now I'm going to hand it back over to Fahim Kadir to introduce our next presenter.
Thank you, Samantha. A fabulous presentation. Now I would like to introduce you to our second presenter, Laura Connolly. Laura is an MSc student in Electrical and Computer Science program in the Faculty of Engineering and Applied Science, and she was this year's runner-up. Laura's work is being supervised by two professors, Dr. Parveen Musavi and Dr. Gabriel Fitchinger. The title of our presentation is Robot-Assisted Surgery, Charting a New Roadmap for Cancer Treatment. Laura, I'd like to welcome you to make your presentation.
Imagine you receive a call from your doctor. You're recently diagnosed with breast cancer and you're finally getting booked in for a procedure called a lumpectomy. By now, you've wrapped your head around what this means. A lumpectomy, by definition, is a procedure where a tumor is carefully removed from the breast. You chose this treatment option because you're advised that it's designed to prevent breast deformity. You arrive at the hospital, get prepped for the OR, and undergo the procedure. You wake up. You should be relieved, right? The lump is removed, so the cancer must be gone. Unfortunately, for many patients, this isn't the case. In fact, this is actually where the waiting game begins. You see, after the tumor is removed, it's sent to a pathologist. Their job is to look at the sample under a microscope and decide if there are any residual cancer cells left on the border. If there are none, the surgery is considered successful. But if there are even a few, the patient may have to undergo a follow-up procedure. The problem is that this process isn't quick. In some cases, the patient is left waiting for days or even weeks to find out whether or not the surgery was successful. And you may be thinking, well, when isn't the surgery successful? Well, sometimes these tumors are non-palpable, which means that the surgeon can't actually feel them. And as a result, currently over 30% of patients actually leave these procedures with cancer left behind. But I do have some good news. This may not be the only way. What if instead of looking at the edges of the sample itself for residual cancer, we look at the walls in the body where the tumor was instead? Well, that's exactly what we plan to do. In my research, we're leveraging revolutionary new imaging tools that can give us real-time information about whether or not tissue is cancerous or healthy. But the question I'm looking to answer is how we can effectively deploy them in the context of a soft tissue space. You see, we would need to perform a very precise scan to be able to identify and localize where residual cancer may be hiding. To do this by hand would mean we not only expect the surgeon to carefully trace each inch of the tissue, but we also expect them to keep track of where they had been and where they still needed to go. And I mean, we all know surgeons are great with their hands, but that's still kind of a big ask. This is where we can introduce robotics. With the assistance of robotic guidance, we can perform the scanning with high accuracy and confidence. We'll attach one of these imaging devices to the end of a robot and use it to perform a systematic scan of the resection cavity. This will work kind of like a GPS. In the same way that a GPS uses satellites to create a map of its surroundings, we'll do that with our robot in the cavity. As it explores the area, it'll create a map of the different tissue types it sees. That way, if we do find any residual cancer, we can use the same robotic arm to guide the surgeon back to that exact location so they can remove it. The same way that your GPS tells you exactly which street to take to get to your destination. Our hope is that we'll be able to provide both surgeons and patients with answers in real time. So, for the many patients who wake up, anxiously waiting to find out whether or not the surgery was a success, we can finally say the waiting game is over. Thank you.
Laura, thank you for that. That's amazing. I always find robotics, and of course, cancer is very topical all the time. So finding a way to sort of help, as you said, you don't have to have that waiting game. Was the surgery a success or not? So before we go a bit into that, you're doing your Master of Applied Science. What made you want to do something like the 3-minute thesis? Because a Master of Science is only 2 years. It doesn't give you a long time to get your research all together. So what made you want to say, you know what, let's give it a go?
Yeah, so I've been doing research since like 3rd year of my undergrad. So I've had the opportunity to present at a couple conferences. And I always found that it was a particular challenge to be able to summarize something that I sometimes don't even understand in a way that people who aren't directly involved in the project can understand. So I thought that this would be like a really good practice for doing that quickly and effectively. And the other thing is I've been in like the Queen's engineering bubble for my whole career pretty much. So I wanted to get to experience other disciplines, theses, and listen to other people's research and kind of get involved that way as well.
That's awesome. And it was so nice to hear you said, you know, you've been doing research for a few years now before you started your master's. And I know that's one of the pillars now of the Principal's new strategic plan is to get more research in undergrad, to get more of you interested in to go into research. And it's clearly worked even before that pillar came into being, because here you are doing this work. So when you're looking at the cancer and the robots, has this actually been shown to work just yet, or is it still in the framework stage of hoping this is going to work? Because we know we can have some great scenarios, but they don't always work.
Yeah, so that's kind of the most exciting part, is that they have used robots in surgery, a lot of more like laparoscopic procedures, and that's been pretty well developed. But breast cancer is like particularly underserved for a number of reasons, just any innovation. So we don't know for sure that the soft tissue scanning will work perfectly. Right now we're working on like the infrastructure and the tools, and then in the next year or so, and hopefully if I do move on to a PhD, then we'll be able to actually implement it in surgery. But yeah, it's still kind of up in the air, which I think is probably the most exciting part, because it sounds like a good idea to me. So I'm hopeful it'll work.
Well, it was interesting you said there was, you know, from current procedures, 30% of people, there's still some cancer left after the procedure. So, you know, some people might say 30% is actually not that bad, but of course we want to make it less than that.
Yeah.
So with something like this, I'm assuming then you've done your number crunching, and so hopefully that'll come down to 1 or 2% only, because I imagine it's going to be pretty tricky.
Yeah, I think the idea is that if they have this sort of double check mechanism where they can say, we did get all the cancer the first time before closing the patient, then hopefully they'll be able to even tell the patient right after the surgery that we're pretty confident we got all of it. And then they would do their follow-up analysis and it would be a good result. So yeah, the idea is that it should be 0, because if you're already going through the process of cancer surgery, you really don't want to have to do that twice.
Correct. And so assuming this works, is this a kind of model that you're looking at that then could be used for other scenarios, such as other cancers?
Yeah, exactly. So any soft tissue resection surgery, this whole framework, we're building it to be very flexible. So you could use whatever imaging device you wanted, and then you would just need the robot and you could kind of run with it.
I bet the hospitals are champing at the bit to find out whether it's all going to work for you, because it would be fantastic for them. And I think this is one of the beauties of the work that you're doing. You're not in medicine or anything, but you're in engineering. And so it just shows how engineering can support our health system as well. So it's not just always the doctors and the nurses and the support staff in hospitals. It's the kind of work that you do outside of that as well. So thank you very much for explaining your part to helping cancer patients down the line.
Thank you.
And I'll hand it back over to Fahim.
Well, thank you, Colette, and thank you, Laura. What a fabulous presentation on such an important topic. I have really thoroughly enjoyed it. I'd like to welcome now Quentin Sang. He's our third presenter. Quentin is a PhD student in translational medicine in the Faculty of Health Sciences and he was this year's People's Choice winner. Quentin is being supervised by Dr. David Reed and Dr. Stephen Vanner. The title of his presentation is "Have Questions About Cannabis? Can You Really Answer Patients' Questions?" Quentin, please.
Thank you for that introduction. Have questions about cannabis? More and more of these signs are popping up in front of pharmacies across Canada since cannabis legalization. Maybe you've seen one outside your local pharmacy. I actually found this one in the lobby of Kingston General Hospital right here at Queen's. Seeing these signs had me thinking, can we really answer people's questions about cannabinoids as a therapy? One of the main reasons why physicians are hesitant to include cannabinoids as part of a treatment plan is because we really don't have the mechanistic evidence for how they work. So no, as of right now, we can't answer patients' questions. But that's not stopping numerous Canadians from turning to cannabinoids without the proper evidence to support their use and perhaps without the full support of their healthcare providers. So here's where I come in. My research focuses on whether cannabinoids can treat pain. More specifically, I'm interested in inflammatory bowel disease, which encompasses both Crohn's disease and ulcerative colitis. These debilitating diseases are characterized by chronic inflammation of the gastrointestinal tract, where over 70% of patients experience daily excruciating pain. Traditionally, this pain is being managed by opioids, but as many of us know, their use is accompanied by severe adverse side effects and has led to a global opioid epidemic. So could cannabinoids be a new alternative to opioids? In fact, many patients with IBD have tried or are continuing to use cannabinoids to treat their abdominal pain, and some do report symptom relief. However, we aren't really sure how this works and if pain is actually being reduced at the level of the gut. So to study this, I take the colon out from a mouse with all the arteries and nerves still attached. From there, I take a bundle of pain-sensing nerves that innervate the colon directly, and in real time, I'm able to see the nerve's activity in response to a painful stimulus, represented by those green spikes you see on your screen. Using this technique, I can look at the nerve's activity before and after a drug, and I can see if that effect is permanent or washes out over time. Cannabinoids act via the type 1 receptor or the type 2 receptor. And what I found is that when we use a drug that specifically targets the type 1 receptor, it reduces the activity of these colonic pain-sensing nerves, which suggests that there's less pain. In contrast, using a type 2 receptor-specific drug, there's no change in nerve activity and thus no change in pain. This is extremely exciting because we now have evidence that using cannabinoids can reduce pain directly at the level of the colon. But more importantly, it shows the potential for us to design specific cannabinoid-based therapies that target these type 1 receptors on pain-sensing nerves and potentially reduce the off-target side effects that may be associated with cannabis use. Ultimately, the goal of my research is to gather evidence to answer patients' questions about cannabinoid therapies and help them and their healthcare providers come up with a safe and informed treatment plan. And who knows, maybe one day you'll see my face on one of those signs outside your local pharmacy. Thank you.
Thank you, Quentin. I always laugh when I shouldn't say I laugh because I find it fascinating, but when we talk about cannabis, because there's so much conversation that goes on about cannabis these days. So thank you for that. It's interesting that you're doing that and already seeing some sort of results of how it's reducing that pain. But when we think about cannabis, just thinking about all the sort of cannabis shops that have popped up over the last year or so, when you're doing this, is there a certain sort of or type of cannabis that you're using? Because we know we have all these different names for the, I'm sorry, I'm being a very generalist here, but there are lots of different types of cannabis being grown or being available to people to use.
Yeah, that's a great question. So cannabis we can buy at the local stores that you see popping up across the town. The main ingredients you find in those, or the main active ingredients you find in those, primarily come from a chemical called CBD, and the other one is THC, which is a psychoactive component. So both of those target these type 1 and type 2 receptors that I'm talking about, but not in a specific way that in the terms of the drugs that I'm using. So the drugs I'm using are being synthetically modeled for the cannabinoid receptor 1 or 2, and those directly target these receptors and therefore reduce pain and potentially reduce the off-target side effects, because one of the main reasons why many people are hesitant to use cannabis to treat pain or other symptoms is because of the psychoactive effects that may accompany THC.
Thank you for that. So that makes us feel a little bit better. So just getting the old gummy bears isn't the way to go. You should be checking with your doctor first, of course, for any of this sort of thing. Not that I know what the gummy bears are, but so with that too, you've had an opportunity to present a couple of times this particular topic, and I'm sure you get lots of people asking you questions. I mean, you're thinking very much on the lines of the gut right now. What made you sort of pick that area to study?
In terms of the gut and IBD, it comes from a little bit of personal experience. I knew someone who had IBD and ended up needing a subtotal colectomy due to increasing pain and pretty much very debilitating conditions that didn't let this individual continue kind of living their daily lives, potentially not being able to participate in stuff they like sports, physical activity. And I thought there must be a better way than traditional opioids, which are again, like I said, contribute to a global opioid epidemic around the world, contribute to many morbidities and mortalities. So I thought there must be a better way, and working with Dave Reed and Steve Vanner at the Gastrointestinal Diseases Research Unit really kind of inspired me to kind of look for new ways to treat this pain and potentially help the next hundreds of thousands of Canadians who suffer from this disease, because Canada has the highest prevalence of IBD across the world. Oh,
is that right? I didn't realize that. That's a pretty scary statistic for Canada. Not very good. And Quentin, one last question for you, if I may. You're in a program called Translational Medicine, and not everyone would understand what that is. So what was your background and why did you choose translational medicine?
Funny you asked my background. My background had nothing to do with medicine at all. I did my undergraduate degree here at Queen's in kinesiology, and I was coming out of high school, going to undergrad, I was extremely interested in sports. I was a varsity athlete for the Gales for a number of years. And then, so kind of going into explaining what translational medicine is, it's the only program in Canada, and from my knowledge, around the world that combines both clinical experiences in internal medicine or surgery with basic science research. So we're able to take the questions we see in clinic that we see with our supervisors or other individuals in the Department of Medicine or the School of Medicine, and we can turn that into a research question, which I did with the help of Steve Vanner and Dave Reed. So that's what translational medicine is. It really prioritizes what we call knowledge translation, which is taking basic science research findings that we see, whether that be in animal models, cells, and kind of translating it so that the general public can benefit from it and really understand it. So the 3-minute thesis was a great opportunity for me to practice that as well.
Well, you've all done very, very well. I know we've only got a couple minutes to go, so I'm going to pass it back over to our Dean to give a bit of a wrap up for you and to say thank you, everyone, for coming today.
Yeah, thank you, Colette, and thank you, Samantha, Laura, and Quentin. These are 3 amazing presentations. I think we get a sort of idea of the kind of research you undertake and the way in which you contribute to society and economy. Thank you all. And thank you everyone for joining us this afternoon. You shared your Saturday afternoon with us. There would be another session coming up at 2:30, and I would really encourage you to participate in the next session at 2:30. But between now and the 2:30 session, there is another one coming up on the PhD Community Initiative, which is an amazing project of how university students, doctoral students are engaged in addressing community-relevant issues. It starts at 1 o'clock right after this session. Please join us if you can. And I wanted to thank Colette and Kim for holding this event and David for making it accessible. And if you have a moment or so to really fill out the post-event survey, please take a moment to really fill it out. Let us know as to your expectations from our programming so we can accordingly put together programs for next year or so. Thank you all for joining us. Have a wonderful afternoon.